there's so many factors for the timing for the administration of these drugs. They started soon after the diagnosis of the NSAIDs. DART, that is dual anti-platelet therapy, is mandatory nowadays. Aspirin and clopidogrel for 1 year. And DART may be shortened or extended, that is 3 to 6 months, or extended up to 30 months in selected patients. Lately, I have just gone through one literature that is only 6 months is more than sufficient. Now, glycoprotein, that is second B, third A inhibitors, aveximab and efficibutide, they are having lesser use than the antiplatelet drugs, and their main indications, they will strongly inhibit platelet function by blocking the binding of trypnosin to activated glycoprotein receptor complex. And they are mainly only indicated for an early invasive strategy, not for unstable angina or NSAIDs patient. Now this again chart shows the brief about the doses and all these things. Next is anticoagulation therapy used to inhibit thrombin generation, effective reducing ischemic events in those patients. Combination with platelet therapy is more common effect. That way I want to state there that it is more effective when they are combined with the antiplatelet drugs. Now the unfractionated heparin, low molecular weight heparin, quantifermex, viability, that is mainly for invasive therapy, and timely reperfusion is important. That is the fourth step. Fifth step is for the risk stratification for individual care plan for every patient is important for their enrollment in the cardiac rehabilitation program likewise. And challenges and special situations are there. That is time is not because constraint of time. Otherwise, that is for unlikely ACS diagnosis if we made the thing. And these are the categories where the patients should not be left for those categories because so many other conditions like Galen syndrome and other things are there. Non-cardiac chest pains, platelet assays, arrhythmias during assays, anemia during ACS. Future prospects are again there for those data. So it is all about 20 minutes within 15 minutes at all. Yes, thank you.
Take the questions later. And now we have our next speaker, Professor Alok Dixit. Professor Alok
They are available in our country as OTC. So they are rapidly being used. They are being used by everyone. And if we see statistics, in 2012 in United States, at least 98 million prescriptions were written in that year alone. And and another 23 million prescriptions drugs were taken as over the counter. So we can see the magnanimity of the uses of these non-steroidal antiplatelets. Another important point is another study where it was seen that 20%, more than 20% of older adults over the age of 65 years, the prescription was for non-steroidal antiplatelets. And these drugs are very much used in older patients. And this was again much larger percentage was of OTCs. And this was 3 times more than being prescribed in the young age. Recent evidences which has shown, which again stresses the point that why we should rationally use this non-steroidal anti-inflammatory drug is that courses of even few days at doses within prescribing recommendation, and they can cause serious adverse effects in susceptible patients. So even if we are giving a dose for a week, or even the first dose can start having a serious adverse effects. This was another study done in 1999, and this stresses us that we can see due to NSAID toxicity, there were deaths of 16,000 people in that year. So you can see if toxicity of non-steroidal anti-inflammatory drugs, which is being used commonly, is there, if it can cause death, then obviously it should be rationally used. Now, mechanism we all know that arachidonic acid, which is derived from our membrane, is being metabolized by cyclooxygenase enzyme, and which leads to formation of the prostaglandins and thromboxane having different functions. They are protecting our GI, they are also responsible for hemostasis, thromboxane, and then prostaglandin also mediate inflammation, pain, and fever, etc. And there are two types of COX, in fact three, but still, if we see COX-1 and COX-2, because we have drugs against these two subtypes of enzymes, COX-1 constitutive enzyme and controls renal perfusion, promotes platelet aggregation, and protects our GI. And if we inhibit this COX, then there is in COX-1, that is non-selective COX inhibitor or the traditional NSAIDs. They increase the risk of GI bleeding, vasoconstriction, decrease GFR, sodium retention, edema, and they have antiplatelet. And COX-2, which is mostly found in inflammatory site, which is inducible and mediates inflammation and pain. If we inhibit this COX-2, then that is COX-6, which is the recent drug. They increase the risk of edema, heart failure, hypertension, cause thrombotic events such as myocardial infarction. So we have two sets of risk, and if with the using of by the use of traditional NSAIDs and these COX inhibitors, COX-6. So depending on these, we have classified these NSAIDs into three types. And one is non-selective or the traditional, which is having less than 5-fold of COX inhibition, and they were called traditional NSAIDs. Another set which were more of, which were preferentially selective for COX-2. We can say them preferential selective, that is including nimesulide, celecoxib, and diclofenac. And another set which is selective COX inhibitor, or the COXIBs which we call them. They are lumiracoxib, rofecoxib, etoricoxib, and valdecoxib. So we at least have three types. And this COX selectivity will have certain effect on the risk factor, on the adverse effects. Now, where we use them, what are the benefits? Obviously, being an antibiotic, anti-inflammatory, analgesic drug, mostly we use them for musculoskeletal pain, for controlling inflammatory, arthropathy, rheumatoid arthritis, using them in dysmenorrhea and menorrhagia, and last but not least, low-dose aspirin as an antiplatelet drug. So we are using for different indications. We have benefits of these drugs. In inflammatory arthropathy, they are analgesic, they are acting as an analgesic, they are subsiding the inflammation, as well as there is improvement in the stiffness and the function of the joint also. That is why they are better drug for inflammatory arthropathy. Now, if we consider if we overview their adverse effects, predominant is GI, which is seen in most of the patients, cardiovascular, renal, hematologic, hepatic, hypersensitivity, we can name any of them. And the GI effect, mostly as abdominal pain and ulcers, the greater risk is with non-selective NSAIDs as compared to the COX-6. Cardiovascular, greater risk is with COX-6 as compared to the non-selective, traditional, and renal and hematologic and hepatic. So we have different. Now, since GI adverse effects are the most common one, and we see that at least 30 to 50% of the patient have dyspepsia, and 70% of the patients who are taking the traditional NSAID, of these 70%, they have lesions. And of them, 20% are having ulcer, and there is 0.2% mortality also. 0.2% mortality also. So definitely GI adverse effects are having their are important, and that is why what the recent evidences show how we can use them. Now these adverse effects, these GI adverse effects, they are increased 2 to 4 times by the use of all the NSAIDs, be it traditional NSAID, be it COX-6, and they are dose dependent. Higher the dose, more the GI adverse effect. Long acting, more risk. You go for long acting NSAID, naproxen, ketorolac, etc., more risk. Concurrent use of aspirin and COX-2 inhibitors, again there is a risk. So don't use, if we are using aspirin and COX-2 inhibitor, then there is risk. Then there are certain factors which can increase the GI toxicity. That is one very important is elderly, more than 65 years of age. Previous reactions, if he already had GI adverse effect by the use of NSAID previously, definitely if he is going to take them second time, he will have the GI adverse effect. Concomitant use of anticoagulants, SSRIs, and steroids, liver disease, chronic kidney disease, smoking, excessive alcohol, and for Indian masala ज़्यादा खा लेते हैं तो भी होता है. So spices. So that is again how we can reduce them. Avoid the long-acting formulations. Lowest possible dose for shortest possible time. Take these NSAIDs with food or milk. This is based on evidence. PPIs, proton pump inhibitors, prophylactically if the patient is more than 45 years of age, and if the NSAID is being given for a longer duration, and if the NSAID is given with PPI in all the patients who are at the risk of GI toxicity. So the risk factor which I have mentioned earlier, if patient is suffering, is having those risk factors, co-prescribe PPI definitely with the NSAID. Then misoprostol is another drug, but definitely PPIs are more tolerated than misoprostol and as well as cost effective also. Paracetamol definitely is better tolerated than NSAIDs in these people who are at an increased risk of GI adverse effects. So if paracetamol can be used, you use paracetamol rather than going for non-steroidal. Diclofenac and COX-2 inhibitors. By the evidence till date, diclofenac and COX-2 inhibitors are the least likely NSAID which can cause the GI adverse effect. And COXs definitely are better than traditionals, but they have their cardiovascular risk. So you have to keep that thing in mind. And if we are using naproxen, as we have seen that diclofenac and COX-2 is the least likely one. Ibuprofen and naproxen, evidence shows that their risk is increased in this patient. So this is one algorithm which has been developed that if there is a low GI risk and there is low cardiovascular risk, that is the patient is now taking aspirin, we can go for traditional NSAIDs. If GI risk is elevated, that is having one risk factor and low CV risk, you go for either for COXen or traditional NSAID plus PPI. And if the GI risk is high with low CV risk, you go for COXen or traditional NSAID plus PPI. But if there is high cardiovascular risk, having low GI risk, go for naproxen. You will see why naproxen is being used. If there is elevated or high GI risk with high CV risk, avoid NSAID if possible. Go for paracetamol or go for COXen plus PPI. If there is very high GI risk, then COXen plus PPI. Then the second adverse effect which I am going to discuss is cardiovascular adverse effect. The rationale for which the COX-2 inhibitors were developed was the traditional NSAIDs were having the GI side adverse effect. And so we tried to replicate this anti-inflammatory and analgesic effect of traditional NSAID, but in turn, what we got is the low GI effect, but added CV risk, cardiovascular risk. So there was risk of serious cardiovascular events, MI, stroke, CHF, etc. And this was because this balance was tilted toward the prothrombotic state. We know the mechanism. Now the evidence started appearing with the Vigor study where this rofecoxib was compared with naproxen. So cardiovascular events were seen in this study, although the significance was not noticed. And later, by approved study in 2003, the significant difference was seen when rofecoxib was compared with placebo. So this led to the worldwide withdrawal of rofecoxib and later valdecoxib. A series of studies which were being conducted during this decade from 2000 onwards to 2014 several studies have shown, and this ranged from that COX-2 increased cardiovascular risk, then meta-analysis in 2001 that COX-2 increased, definitely COX-2 increased cardiovascular risk. Approved study in 2005 again showed that COX-2 increased the cardiovascular risk. And then meta-analysis in 2006 in first time showed that COX-2 and traditional NSAID both were increasing the cardiovascular risk. And then a Danish study in 2014, it showed that increased cardiovascular risk for COX-2 and diclofenac. So we can see the range of studies were being done during this decade, and evidences were being collected, and what we have come to conclusion was that this non-steroidal anti-inflammatory drugs were causing cardiovascular effect, be it toxics or traditional. So there were a few questions that should be answered.